All right, this third segment and final segment, we're going to be talking about treatment for hormone therapy. The thing I'd like to point out to you, and that I think it's really important for you, is that number one, you need to start on hormone therapy as soon as you become symptomatic. There's no I'm too young, I'm too old situation. If you're 35 years of age and you're having hot flashes and night sweats and mood swings, then you need to start on hormone therapy at that point in time. So I would recommend that you start on a natural plant-based bioidentical estrogen. I'd recommend you start on something in the form of a patch, and I would start you kind of low, and I give you some samples or a prescription, and then we have you try it, and then we have you come back and see us. But what I do is I give my patients the freedom to kind of adjust that dosage, and so I have them start low, and I give them permission. It's okay to up that dosage because I want to get rid of their symptoms, as we talked about earlier. So whatever your symptom is, if it's hot flashes or night sweats or headaches, whatever, we're going to keep upping the dose till we get rid of those symptoms. And once we get rid of that, and then you're stabilized, then that's the dose that we're going to keep you on. Now, you may say, well, wait a second, what about progesterone? I've still got my uterus. I need to take some progesterone, and that's correct. You do need to take some progesterone. And why is that? Because your estrogen may cause that lining to build up a little bit inside, and so you're taking progesterone to help slough that lining. So you go, well, wait a second, does that mean I'm going to have periods? Possibly. So if we put you on a low dose that just gets rid of your symptoms, every lady's a little bit differently. What I do with my patients is that I ultrasound them when they come back, so I'm checking to see what they're lining so I can see how frequent we need to give them their progesterone. But you're going to need, if you have your uterus, you're going to need some progesterone, and it needs to be a natural progesterone. So you need to make sure your doctor puts you on a natural, nothing synthetic. You don't want to be on synthetic progesterone because that really blocks your estrogen receptors, and we talked about that. That'll make your estrogen not be as successful. So if you take a natural progesterone, your progesterone that you're taking for, usually we give it to our patients for 10 days each month, that's kind of the glue that holds all that lining in place, which is not too thick of a lining. So when you stop taking it, you would expect to have a period after that. So just remember, if you take it for the 10 days and you stop and you have a period 3 or 4 days later, that's normal. If you take it for 10 days and you stop and you don't have a period, that's great. That means your lining's so thin there's nothing to come out. So that's a good thing. If you're taking it for your 10 days and you start bleeding on those 10 days, especially the day 6 to 10, that tells me your lining's starting to build up a little bit. So we're going to have to up the dose of your progesterone or adjust your estrogen. Now, if you start bleeding in the first 5 days, that tells me your lining is significantly thick, and we're going to have to watch that really closely. I usually have them up the dose of the natural progesterone and take it longer for like 12 days. But sometimes you can have some fairly heavy bleeding with that, and occasionally your doctor may recommend a DNC to kind of remove that thick lining and then start you on your hormone therapy, and then life's going to be a little bit easier for you. Now, if you've had a hysterectomy, then you don't need to be on progesterone. You just need to be on your estrogen and kind of balance that out. Now, you may ask and you say, well, what about the testosterone? You talked about earlier that, if you still have your ovaries, they're making testosterone. And that's true, they do. And in the early part of the menopause, your ovaries are still continuing to make progesterone, and so you may not need that. But if you happen to be late 50s, 60, and all of a sudden your libido is starting to drop off, your estrogen, you're feeling fine from an estrogen point of view, then we might need to add a little bit of testosterone to kind of bring that back up. And that's where a compounding pharmacy, we have them, they make up these little lozenges of a very low dose that you put under your tongue Monday night, Wednesday night, Friday night, and that slowly brings that testosterone back up. Same thing for ladies, if you've had a hysterectomy and your ovaries have been taken out at the time of your hysterectomy and you're on your estrogen and you go, man, I don't have a libido, well, you need to be on some testosterone because your 75% of your testosterone left when your ovaries were taken out, and apparently your adrenals that make the other 25% haven't kicked in. So you need to go to a compounding pharmacy, and we use like a really low dose, like a 1.25 milligram sublingual 3 times a week. It's going to take, going to take 3 or 4 weeks before it kind of gets back into place. It's not like Viagra where something's going to happen that night. Testosterone is kind of a slow progression to kind of get you back to normal. So once we get you on your hormone therapy and you're kind of balanced out, then we're going to stay on that long term. Now, let me just kind of talk about some problems you may experience when you're taking hormone therapy. The first thing is that taking a transdermal, we start with patches, or we use spray, or we use gel. If you get a reaction to the patch works great, like the patches, but if you're starting to get a reaction and the adhesive is causing you to get redness, or blistering, or it's falling off, or it's itching, then it's not working. Then you're going to have to bail out of that, and you're going to have to try something different. If you take the spray and you use the spray and the spray works well, but you go, you know what, I'm still having hot flashes, still having night sweats, and that doesn't work for you, you may be one of the very few people that your skin just doesn't allow estrogen to get through for some reason. And that's kind of rare, but that does happen. So if you tried the patch and you tried the spray, or even you tried the gel, and none of those are really working, then you may have to go to taking an oral type of estrogen. And let me just kind of say right here, if you're going to take an oral natural estradiol, that oral estrogen, especially generics, are not going to make it 24 hours. If you're taking estradiol, you're going to have to take it in the morning, and then you're going to have to take it around 4 to 6 in the afternoon. Because if you take it at bedtime, it's going to wear off at about 4 or 5, and then all of a sudden you're going to be feeling poorly in the early evening, and it's not until you take it at nighttime that all of a sudden it comes back up. So taking generic estradiol, you've got to make sure that you're taking it, if you take it first thing in the morning, then you got to take it probably around 4 to 6 in the afternoon. And then you'll do okay. And just remember, the other thing is too, if you're a smoker, smokers don't do well with oral estrogen. I don't know what it is. There's something about the receptors or the way it's metabolized in their liver, but it just doesn't seem to work. So if you're a smoker and you're on hormone therapy, then you're going to need to go on a patch, a spray, or gel, and hopefully that works for you, because then it works great. For smokers, taking the patches or the spray or the gel works extremely well. Now, I know what you're thinking. I can see the wheels turning there. You're going, wait a second. I'm a smoker, and you're putting me on estrogen. Isn't that dangerous? Aren't I going to get blood clots? Well, remember what we talked about before. All the blood clots occurred in women who took birth control pills. They took 10 times the dose of birth control that we normally have today. And so putting that into perspective, just remember, I'm going to give you some numbers. When birth control pills first came out, the amount of estrogen in them was 200. Just remember the number 200. What you're taking in your patch is between 6 and 12. So, I mean, and you're taking it transdermal. It's going through your liver and breaking down that cause the synthetic estrogen to make these clotting factors that cause ladies to get blood clots and to have strokes. So no, you're smoking and taking a natural transdermal estrogen is not going to be a significant risk factor for you getting a stroke. You got to remember that unfortunately in the medical profession, I hear this frequently, that ladies they're smokers and they're told, oh, you're at risk for a stroke. It has to do with birth control pills. So as long as you're not taking birth control pills, you're going to be okay. Now, the other thing is that sometimes your doctor may say, well, I'm going to follow your blood levels. I don't really follow blood levels. I go based on how you're feeling. If you're clinically feeling good and your symptoms are gone, you don't really need to do a blood test. But I'll tell you what's interesting is that you may have somebody come up to you and they may say, oh my goodness, I see you're taking 1 patch or 2 patches. And that's the other thing. I have some young patients and I put them on a patch and they're on the highest dose of a patch, but they're young. They're in their 30s. And unfortunately, they've had to have a hysterectomy for whatever reason. And so the 1 patch doesn't do it. They have to take 2 patches. And so the pharmacist goes, oh my goodness, you're taking 2 patches. Well, you got to remember, when those patches were designed, they never thought that 35-year-old ladies are going to be on estrogen therapy. They were designed for people older. But the key thing is that sometimes you have to take a higher dose to get you back to normal. And so I've encountered other physicians saying, wait a second, why are you giving them all this high dose of estrogen? And I go, wait a second, let's put this into perspective. Let's assume that this 35-year-old lady still has her ovaries and they're working great. She's cruising along, she's doing fine, and we check a blood level on her right when she's ovulating, and her blood test is like 350 on the standard lab test. We'd all go, great, her ovaries are working, she's doing fine. But why is it when she's had a hysterectomy and I put her on hormone therapy and she's taken 2 patches and her estrogen level's 150, maybe 180, 200, and everybody's all worked up. They're going, oh my goodness, you're taking all this high dose of estrogen. You got to remember, what we're taking with hormone replacement therapy is way less than what her ovaries are taking. And nobody's going to go to that 35-year-old and say, we got to take your ovaries out, for crying out loud, you're making way too much estrogen. You've just got to put it into perspective. I had a 55-year-old lady the other day in her office, and my physician's assistant checked her estrogen level. I'm not sure why, but I think she may have requested it. And she's having regular cycles, 55 years old, having regular cycles, and her estrogen level was 350. I was kind of blown away by that. So I played a little trick on talking to my primary care friends, and I said, say, I've got this lady's 55, and her estrogen level is 350. What do you think? And they go, oh my goodness, you got her on too high a dose of estrogen. And I said, no, actually, that was her ovaries making that. They go, oh, okay. And I'm like, why is it that it's okay for your body to make 17-beta estradiol, but it's not okay for you to take 17-beta estradiol and get you up into a normal range? So you have to put things into perspective. And so I think that that's where part of the confusion lies, in the fact that a lot of physicians and pharmacists think that hormone replacement therapy is high dose. It's actually way less than birth control pills. And I've seen ladies in their late 40s where a primary care doctor puts them on birth control to regulate their bleeding, and I'm going, good grief. They're taking 2 or 3 times a dose of hormone therapy, and then when they start bleeding, their primary care goes, well, double up on your pills for the next 4 or 5 days to stop the bleeding. So they're taking 6, 8 times what I would be giving them in hormone therapy, and now they're taking synthetic estrogen. Remember, we talked about that. That can cause blood clots. So when you go and once you go in your late 40s and somebody puts you on birth control to regulate your bleeding, that's a problem. Putting you on a natural plant-based bioidentical estrogen is not going to be a problem. So it's very important when you're seeing somebody on your hormone therapy that you see somebody that understands hormone therapy, who knows what they're doing, has lots of options, and can definitely get your problems taken care of. You just have to be a little bit creative. And there's those of us that just love doing this kind of thing. But I tell you something, it's a little bit of a challenge. But you know, don't give up. Make sure that when you're seeing your physician, you keep going back, keep following up so that they can finally get you dialed in. But once you're feeling good, I'm telling you, you're going to really appreciate how well you feel.